Hello, everyone, and welcome to our 5th NDEWS Presents webinar. We are the Coordinating Center for the National Drug Early Warning System and the National Institute on Drug Abuse, and we're happy that you were able to join us today. The NDEWS PI is Dr. Eric Wish, and the NIDA project scientist is Moira O'Brien. My name is Erin Artijani, and Kathy Garcia and I will be the facilitators for this webinar. We are part of the Coordinating Center team for NDEWS, which is supported by funding from NIDA. For those who are interested, you can find detailed information about NDEWS, recordings of prior webinars, and invitations to future webinars on our website at www.ndews.org. You will also find all of our reports there and other items of interest, like instructions for joining our NDEWS network and participating in ongoing discussions with more than 1,200 experts and concerned citizens from across the United States and 20 other countries. We developed the NDEWS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This month, we will be discussing synthetic opioids and counterfeit pharmaceuticals and street drugs in Canada. Some of you may have heard about some recent overdoses in British Columbia, and one of our presenters is actually from there. We're very fortunate to have 3 experts, Dr. Matthew Young, Senior Researcher and Policy Analyst for the Canadian Center on Substance Abuse, Dr. Jane Buxton, Physician Epidemiologist, Harm Reduction Lead at the British Columbia Center for Disease Control, and Ms. Michelle Craig, Acting Executive Director for Addiction and Mental Health in the Government of Alberta. This webinar will be approximately 2 hours long, and we encourage questions during and after the presentation. Please post your questions in the Q&A box. Those that I can answer as we're going forward about technical issues and things like that, I'll answer right away. And for the rest, we will hold a brief Q&A session after Ms. Craig's presentation is complete. Our panelists, Kathy and I, will do our best to get to all of your questions. And we will also post a Q&A with responses to your questions on the ndews.org website after the webinar, along with a full copy of this webinar and copies of the slides from each of our presenters. So we hope you enjoy this webinar, and thanks again for joining us. And I'm going to turn things over now to Dr. Young to start things off.
Well, thank you, Erin. Can everybody hear me okay? Great. So yeah, first of all, thank you so much for this opportunity to present for the NDEWS webinar series. It's been a great series, and I thank you all for the work that you're doing. The rich discussion on the listserv has been really helpful in the work that we're doing up here. I'm here to talk a little bit about the situation of synthetic opioids and counterfeit pharmaceuticals in Canada. I'm going to give a bit of an overview of the situation and who we are, and then I'm going to turn it over to 2 of my colleagues who are more well-positioned to speak to some of the specifics around what's happening in the interventions that are taking place in both Alberta and British Columbia, which have kind of emerged as a bit of the epicenter of this recent kind of crisis in overdose deaths in Canada. So first, I'm going to tell you a little bit about who the Canadian Centre on Substance Abuse is. So we're the only agency with a national mandate to reduce harms of alcohol and other drugs on Canadians. We were created by an act of Parliament, and our mandate is to provide expert advice and evidence information to parliamentarians.
Dr. Young, please remember to share your screen so that everyone can see your slides.
Oh, my apologies.
Thank you.
How's that?
That looks good. We can see your slides now. Thank you.
Great. So the Canadian Centre on Substance Abuse works in a number of different areas. This is our kind of national priority and areas for action. We do work in a lot of different areas. That's what this is about. So I'm here more to talk about novel synthetic opioids and counterfeit pharmaceuticals. And this has largely come out of a bulletin that the network that we lead, called the Canadian Community Epidemiology Network on Drug Use, put out earlier last month. So maybe before we go into that, I'll give a little bit of overview of just how we got here. So from the most of those attending this webinar will probably, this situation will be very familiar to them. In Canada, between the 1990s and the 2010s, we saw an increase in opioids, both prescribed and dispensed in Canada. During this time, many people became dependent, and this kind of the emerging harms from these opioids, in response to those emerging harms, we initiated, our organization brought together a pan-Canadian group of individuals to kind of talk about a strategy to address this problem. This was called First to No Harm, Responding to Canada's Prescription Drug Crisis, and this group was brought together in 2013. What occurred before that, but then up until and has been ongoing, were a great number of interventions that were introduced to respond to this crisis. This included prescription monitoring programs, increased understanding and education of physicians, guidelines to when prescribing opioids, as well as increased attention to the issue from law enforcement. One of the things that the results of this was a decreased availability of diverted opioid pharmaceuticals available in the illicit marketplace. And I think what we're here to talk about today is in some ways the unintended consequences of these important interventions. Between 2009 and 2014 at the national level, there were 655 deaths in Canada where fentanyl was either a cause or a contributing cause. And there were over 1,000 drug poisoning deaths where screening indicated the presence of fentanyl. Seizures and anecdotal reports, however, from partners such as the ones you'll be hearing from later in this webinar, indicated that a lot of the overdoses were occurring among people who thought they were using something else, who didn't necessarily know they were using fentanyl. These included oxycodone, heroin, cocaine, or other substances. So I'm going to tell you a little bit about who CENDU is. So CENDU was originally modeled based on the US CEWG, Community Epidemiology Work Group. And so what CENDU is we're a sentinel surveillance network made up of representatives from across Canada. Each representative or CENDU site collects local level data and kind of reports in or shares this information between other CENDU site representatives, as well as nationally here at the Canadian Center on Substance Abuse. We coordinate this network, and then we kind of release alerts and bulletins nationally that allows us to share what's happening in one area of the country with what might be happening in another country. And that kind of a heads up can sometimes be very helpful. So what alerts and bulletins have we released that have kind of led up to the situation we're at right now? Here are some of them here. This is in 2013. It was really in about June 2013 when we first saw powdered fentanyl. This was a result of like a seizure that occurred in Montreal, and we also had some word of this powdered fentanyl in British Columbia as well. But it was really in about February 2014 when we started hearing from our partners in British Columbia and Alberta about the green jellies or green beans, these pills that were kind of pressed to appear as though they were OxyContin tablets, but were found to actually contain fentanyl. And it was we immediately issued an alert because our partners were saying this carried with it a great risk of overdose. About 1 year later, we released another alert saying that there indeed were increases in fentanyl-related overdoses, but at the time we didn't have national level data about they really clearly describe the quantitatively the extent of these overdoses. It was in last summer in August that we released a CENDU bulletin on deaths involving fentanyl in Canada, where we went out to each of the coroners and medical examiner offices across Canada and compiled all the deaths data of deaths that involve fentanyl. One of the difficulties in Canada is that each of the provincial and territorial governments have their own coroners and medical examiners offices, and this data is not always easily combined in kind of a single number. And so this is something that our colleagues are working to develop better national level data on drug-related deaths, but at the time we don't have any. Following this, we published a paper in the Canadian Journal of Addiction about the rise of overdose deaths involving fentanyl. We put out another a bulletin looking at kind of a scan across Canada, the availability of take-home naloxone in Canada, and that leads us to where we are right now. This novel synthetic opioids and counterfeit pharmaceuticals. One of the things that we heard early on about our CENDU bulletins was that our partners said, we don't want to just hear about what substances are out there and how dangerous they are. We want you to tell us what you know about what we can do with that, what we can do about it. So this bulletin is really focused on the appearance of these counterfeit pharmaceuticals and and what the kinds of active ingredients and what are the novel synthetic opioids that are found in these counterfeit pharmaceuticals, and then kind of so what. So who needs to know this information, and then what can they do about it? The novel synthetic opioids that we focused on in this bulletin were the fentanyl and fentanyl analogs. We included W18, even though we are aware that there is information out suggesting that it's not an opioid, but it was included. It has been included in products sold as opioids, and therefore kind of did hang together with the rest of these substances, we felt. And then U4770, H7921, MT45. So in reaching out to many of our partners, and we kind of said, what are the implications of these novel synthetic opioids in tablets and powders? Really, for those working in public health and harm reduction, is that it really, the presence of these dramatically increased the risk of overdose, because people using them really don't know what substance they're using or how much is included. And if you don't know how much, what or how much is included in the substance, this dramatically increases the risk of taking too much. The other piece in here that I think is oftentimes misunderstood in the larger media, at least, is that when we talk about a lot of these substances, particularly W18, people talk about the potency or and how strong it is, but really the issue here is the variability of dose from one tablet or powder to the next. And it's that really increases the risk of overdose, not simply the potency or the toxicity. It may be argued that with very highly potent or toxic substances, it's harder to get that mix right in these clandestine illicit labs that may be pressing these into pills or preparing these powders. But really it's the variability. And this is important when warning people who use drugs or others, because if they just hear that it's strong and they purchase a counterfeit pill that they know is a counterfeit pill, and they consume some and they don't experience a very large subjective effect, they may just discount the message. Whereas what we're really talking about here is that the one that they bought may contain an appropriate or a low dose, but then the next one may contain a lethal dose. And so that that's an important piece of the information that needs to be communicated very clearly. For those with access to naloxone, we consulted our partners, and even though the efficacy of naloxone has not been evaluated for all the novel synthetic opioids, in theory it should temporarily reverse the effects, and so it should be administered immediately. And this is underscored by the fact that administering naloxone when not indicated will not hurt the person. It's unknown how long a lot of these novel synthetic opioids will stay in the system, and it's also unknown the doses that individuals have taken, and so repeated doses may be required, and this is makes it particularly important for any bystanders to call 911. We also include in this bulletin, if you're interested, implications for poison control centers, laboratories, and law enforcement. And I kind of recommend that if you're interested in some of the information from this bulletin, you can access it via our website, www.ccsa.ca, and you'll be able to find our send-to alerts and bulletins on the website. And we have alerts and bulletins on other issues as well. So I would encourage you to look to the website. And so that's kind of a general overview of the situation and how we got here in Canada. And now I'm going to hand it off to my colleague, who's also happens to be a SENDU site representative from British Columbia, where they've really been on the ground dealing with a lot of the issues right now, and to provide a lot more context and a lot more specifics. So I'm going to hand it off to my colleague, Dr. Jane Buxton. Thank you.
Thank you. People see my screen okay? Or am I sharing my desktop?
Your presentation looks great, Jane.
Wonderful, thank you.
Thank you.
So thank you very much, Matthew, for an excellent summary introduction, which is really making my life easier for me to come into my presentation. As was mentioned, I'm the harm reduction lead at the BC Centre for Disease Control and have been involved with the CCENDU since about 2002, I believe, when I started a job working at Vancouver Coastal. What I'm going to do in my presentation is really just give more of a hone down on what we're seeing and what's happening in British Columbia. And I'm going to start off with some news items, news alerts. So if we look back to Thanksgiving, and this is the Canadian Thanksgiving in October 2014, you can see the media were talking about 12 overdoses, including this was happening with one batch of potent heroin was thought in Vancouver. The next, a little bit later, there were 31 overdoses at Insight and somebody's death in the hostel. Nobody died at Insight, even though there were 31 in a very short period of time. And then the police were able to obtain some of the flats that were thought to be responsible and get it tested. And then, as you can see, this is within the first alert came out October 13th. This was October the 15th. And we're able to say this was caused by straight fentanyl. There was no heroin in the substances tested, just fentanyl and cocaine. And then the police showed some examples of the flats that people had been using. So this really struck home that people thought they were using heroin, but it was fentanyl. And we'd also heard in BC reports of people having an opioid, apparent opioid overdose when they thought they were just taking crystal meth. So this led us to a couple of questions about who is taking fentanyl, where do they know they're taking it, and whereabouts are they when they're taking it? And where is it geographically? So we have a network of about 300 harm reduction distribution sites throughout BC, and the supplies are distributed at a provincial level, which means we have good relationships with sites, and it enabled us to go in fairly quickly. So this was early 2015. We found 17 sites around the province who are willing to administer a one-page survey asking people what they'd used in the previous 3 days and to pee into a pot. We thought there would be problems, but people seemed to be quite willing because there was this high concern around fentanyl. What we found was 30%, almost 30% of people had fentanyl detected in their urine, but of these, 73%, so nearly 3/4, had not knowingly taken fentanyl. We found that the positive urines were throughout the province. The rates did vary by health authority, but there were positive results in each of the health regions, and we have 5. And we also found, when controlling for age, sex, location, fentanyl was more likely to be positive if an individual reported taking fentanyl, which seems very reasonable, but also if they were taking crystal meth. So, I mean, our next question is really who is dying due to illicit drug overdoses and how often is fentanyl detected and what's happened over time and who are these folks? We've had a long-standing relationship with the coroners, certainly when I was being involved with CENDU going back to the early 2000s. They were sharing with us the numbers of what is called illicit drug overdose deaths. So to clarify, these are deaths where a drug is thought to be illicit. So this may be somebody taking a prescription opioid or a prescription drug which is not prescribed to them, or it may be heroin or crystal meth. But at some point in the investigation, it's determined that this is an illicit drug overdose death. And also these are non-intentional. This excludes people who have intentionally taken illicit substances and died. Interestingly, you can see there was a peak back in 97, 98. And that was when half of the deaths were in Vancouver region, and there was an increase in the potency of the heroin that was detected. The enforcement, health, and the city worked together using the 4 pillars approach. And you can see after 1998, there was a decline in the overdose deaths. Most people say, was some of this responsible to Insight? So I will tell you that Insight opened in 2003. So that has helped to keep those deaths down. Now, if we look at what happens after that, overdose deaths seem to be around or below sort of 200, 250, until 2011 when we saw a little bit of a spike. That again was related to heroin, and it was an increase in potency of the heroin. And it settled a little, but you can see how it has increased dramatically since then. And in 2015, we had the highest number of illicit drug overdose deaths ever recorded in British Columbia, and the highest rate. And this rate is higher than motor vehicle accidents, plus deaths related to HIV and AIDS. We have results in an ongoing manner. Each month the coroner shares data. Obviously it's provisional data, which gets revised when cases are closed and more information is found. But very distressingly, you can see in 2016, for the first 6 months, there have been 371 deaths, which means we're on track for 750, which compared to what you can see we've had previously is really, really quite unfortunate. I am very visual, and I find the graph really helps to show, not just having numbers. And I'm going to show you some maps which are also very visual. We have mapping that is much more specific. We can actually map by site of overdose and whether
Sorry, it looks like Dr. Buxton has had a glitch on her end, but she might be back with us now.
Am I back with you?
Okay, yes, we can hear you, thank you. And your map is showing.
Sorry, it just told me that my I was unstable. At least my web was unstable. Where did I cut out?
Right here. You were just introducing your map.
Okay, so these are maps that the actual rates are determined by where the overdose occurred, if that's not available, where the death occurred, if it wasn't a medical facility, and place of residence. So there's a hierarchy of where it is. So here we go. The lighter colors are the lower rates, and you can see the darker colors are higher rates. So this is 2010. This is 2011. You can see for FE, which is Fraser East, it was a bit higher, and that's where the high potency fentanyl, high potency heroin was. This is 2013. You can see how it's getting darker. This is 2015. Vancouver, obviously, is the highest rate here, and this is where we were in 2016. So I think that really shows how quickly and how much this has increased. This is all illicit drug overdoses. This is not just where fentanyl is detected, but you can see how the rate has increased. So if we look at the percentage of illicit drug deaths where fentanyl was detected, this has also climbed very, very rapidly, from 5% in 2012 up to 31% in 2015, which we thought was pretty horrific. But if you look now for 2016, and what I'm displaying here is the rate from January to the end of May, so 5 months, because there is a delay in actually getting results from the toxicologist. You can see here that it's now up to 60%, so it's huge. It's doubled, and this is probably an underestimate as more toxicology results come in for the month of May. So who is it? So I'm just displaying here those where fentanyl was detected. You can see here that in 2016, we have had more deaths where fentanyl was detected than we had, and this is the first 5 months, and this is higher than we had in all of 2015. This is where fentanyl was detected by age group, and you can see it tends to be the 20 to 39-year-olds are the highest age group. 40 to 49 is also quite high. It's slightly younger than we usually see when people are prior to the fentanyl, where people were actually dying. And as always, we see that females are much less representative than males, who are 3.5 times more likely to have fentanyl detected. So the next question comes to, what are we doing about it? And one of the things we want to make sure is that we're developing appropriate messaging. Dr. Young mentioned unintended consequences, and what we don't want to do in this occasion is to promote that there is certain substances around that are more potent, such that people start looking for it. We also know that we have different groups of people who are using and who are unfortunately dying, from people who have chronic opioid use, as well as people who are the experimental party use. And then I'll talk a bit about increasing our access to naloxone, some research we did about calling 911, and a little bit about declaring the public health emergency. So we did a study, and we had funding actually from the CCENDU group to do this. And we did a couple of focus groups, and this was with people who had chronic substance use, and to find out what it was that they wanted in the drug alerts. And what we heard was they wanted findings to be timely, they wanted it to be shared in different outlets, they wanted it to be very visible and accessible, they wanted to know what the relevance was, using simple language, words that imply harm, date the posters and remove them. We heard that there had been lots of posters that were put up and people just left them up there. Say what to look for and what they could do and what actions to take. And this is just an example. This was one that came out around the time when we were seeing those overdoses related to fentanyl, the 31 overdoses in the downtown east side. So using words like toxic or contaminated, where it can be found, and it was mainly in the oxys and the heroin that people were finding it, and what does it mean that it increases the risk of an overdose, and encouraging people to get trained with regards to naloxone. And we often say in Vancouver, if somebody is injecting their drugs, to use Insight. We also obviously have safer drug using messages, and this has changed over time. The standard one always used to be don't use alone, and we've had to revise that, having had a number of deaths occurring in people who were using with someone else. There was a 30-something couple who used to celebrate. Both of them used it. Unfortunately, both of them died. We had a 16 and a 17-year-old who used together. Both overdosed. One came to, but the other one unfortunately died. So our messaging has changed to have a sober buddy who can call for help. Make a plan. If you're planning to use, tell somebody you're using. Don't lock your door. Get somebody to check on you. And, you know, we're all aware of some famous personalities that have used opioids or have used fentanyl, where unfortunately, due to stigma and other reasons, have used alone and have died. And the other messages are very standard. Test a small amount first. We actually used to say taste, and then realize that sometimes people are actually putting their tongue and tasting it rather than just using a small amount. Know your tolerance, don't mix. If somebody overdoses, dial 911 right away. And getting the message across, you don't know what you're taking. It may have W18. We don't know if naloxone works for that. But often these substances are a combination, and naloxone will take the opioid out of the picture. And discuss treatment options. So not just focusing on what you should do at the time of use. And what we found is over time, and our relationship working with enforcement and others, is that we can adapt the same messaging. Rather than having an abstinence approach by some folks, is using that if you choose to use, this is what you should do. So I showed you the posters, which are the ones that we put down in the downtown east side when something happens, and we get the message out. It goes up at places that, and agencies where people who would be having, who have chronic, using chronically, would go. But as you saw from the, when we looked at the ages of people who are dying, we did see it was kind of between the 20 and 40-year-old, and not everybody was street entrenched. There were people who were experimenting. There were people who were perhaps regular weekend users, but were not using on quite, hadn't developed tolerance and weren't using quite so much. So we developed more of a public service announcement, and this was working with the police as well as health and the coroners. And Know Your Source with a question mark was developed, and this was really think about where are your drugs coming from? Do you know your source? Do you know what's in them? We, as I said, targeted the less experiential ones. This poster, much to my surprise, was very popular, and when we piloted it with youth who use drugs, they thought that one was going to be the most impactful. It made me cringe rather when I saw it, but this was the input that we got. We got feedback from other places who suggested different things around changing the language, slightly changing the images. There was a website developed, which was entitled Know Your Source, and there was information about fentanyl, the posters, but also where people could call for help and what to do. And you can see that we had quite a few visits, not just from Canada, but elsewhere. We also, along with this, introduced the social media campaign, and I was unaware that you can actually pay money to make sure that the ads appear on people's Facebook. And so you can target 18 to 40-year-olds who are in a 25-mile radius from major cities. And at $100 per day over a 2-week period, it meant that over 200,000 people viewed the Know Your Source campaign. So going back to what else we've done, talking about take-home naloxone, I'm delighted to say that we actually started the program before we started seeing increases of fentanyl. And this was following the increase in overdose deaths that we saw in 2011. Many of you in the US will say, yes, you're a bit late really, because I know it's been running at that point for 16 years in some states within the US, but we got there. We constantly evaluate our program, and we started off by having very nondescript cases that were just plain dark color. We quickly learned that people were really proud to carry their naloxone. They wanted to have it obvious what it was, so we ordered cases from a company in China who made them specifically for us. We had the red cross with naloxone on, the white zip so people could find it in their backpack. It has a clip so it goes onto your belt. We did start off with having 2 ampules of naloxone. We've had to increase to 3 because we're finding so many people are needing more than 2, or that there's more than one person who is overdosing at one time. Where are we now? So since we started, we've dispensed over 11,000 kits. We've trained almost 10,000 people. We do train people, service providers, friends and families, as well as people who use opioids. Our program is actually targeted at people who use opioids who are at high risk. So that's where we're actually targeting. We are aware of 1,700 kits which have been reported as being used. There is a form inside the kit which we ask people to respond so that we can get better information. We find about half of people will actually fill in those forms, but that does give us good information. We have 270 locations, which are sites throughout the province. 34 of these are emergency departments, and that number is increasing as all emergency departments are becoming take-home naloxone distribution sites. So if somebody comes in having had an overdose, and we know if you've had one overdose, your risk of a subsequent or of dying is much greater. All emergency departments in BC are becoming take-home naloxone distribution sites. We're currently in 3 of the correctional facilities, and when I say in, this means that people are trained whilst they are residing in the facility, and then when somebody is released, they take the kit home with them. One of the most important steps we feel is calling 911. As Dr. Young said, people don't know what they're taking, they don't know how much is there. Even if you are able to give naloxone, the overdose may come back when naloxone wears off in 30 minutes or so. So we really emphasize the calling 911. When we first started, we realized only about 45% of people were calling 911. We've reinforced it, and we now know more and more people are calling, but it's still not 100%. As I mentioned, we had those forms within the kits, and when we look at those, we find that people are 10 times more likely to call 911 if the overdose is occurring on the street rather than it occurring in a private residence. And the reasons for that, and we did some qualitative, we do ask, about a third it's fear of the police. Others were thinking that it would actually, the person would be fine. When we look at the percent that call 911, and these are the 5 regions within British Columbia. Vancouver is obviously around Vancouver region, very urban. We have and where the downtown east side is. The Vancouver police have had a policy for the last 15 years to not routinely attend overdoses. If there's a death, if there's violence, if the first responders, the ambulance are concerned, then they will go. But you can see that about 29% of the time, the police actually attended. So here, the places where people feel more comfortable and more likely to call 911 is where the police are less likely to attend. And you can see with interior health, the percentage of calling is far lower, but the police do have a more 3/4 of the time attend. It's my understanding, and I'm waiting to get this in writing, that this has been, and obviously we've been talking about this, but there is a new policy such that the police will not routinely attend in all overdoses in BC. One of the questions that comes up is who actually gets there first? We have a very efficient fire service, and sometimes in the rural areas, the fire are more available and can get there more quickly. So then if we look at who gets there first, in fact, the police only get there first about 12% of the time. There is, in the northern region, which is a very there's a low population in the northern area, and the police do get to overdoses more frequently. But generally speaking, the ambulance gets there 45% of the time first, and fire 43% of the time. Again, this is looking at the forms that we added this question because we thought it was important after we did our last evaluation. So this is from the last 15 months. So an update on the naloxone in BC. All ambulance crews can administer naloxone and carry it. In the past, it was just paramedics that were trained to level 4. Now level 3 can. We have trained firefighters. There has to be a collaborative agreement between the fire department and the municipality, and they get approval from the on-call physician. But there are now, I think, about 45 municipalities where the fire can carry and administer naloxone. Health Canada removed naloxone from the prescription drug list in March of this year, and 2 days later it was deemed to be available at pharmacies. People can buy it from behind the counter. And early April, over 1,000 pharmacists were trained, and we developed a webinar, and we had some in-person sessions around the province, and 1,000 people actually attended those in person. And I know in the US, many folks have, the Adapt Pharma has been approved. That is just going through the process here in Canada. But in July, our federal health minister introduced an interim order which will allow importation of the nasal spray from the US. So this is something that we're hoping will be available in a few weeks' time. And then it's a case of distribution, who's paying for it, because this is obviously far more expensive than our current ampules. The public health emergency was declared in April, and the idea of this, you know, you saw the numbers, you can understand the reason for concern. And one of the things it helps us to do is to collect better information. By making overdoses reportable, such as when somebody attends an emergency department or when the ambulance is called, we can get much better data. So rather than just aggregate numbers, we can get personal identifiers and see where we're missing. So if somebody's coming into emergency room, have they recently been to treatment? What else has been going on? And similarly, when people have deceased, then that, again, we can follow up and see, okay, where did we miss? Where do we need to target? So as I mentioned, emergency departments, emergency health services, both from the ambulance dispatch, but also from the patient care reports and the naloxone administration. There is some delay there as this gets entered by the first responders, but it gives us reasonable good information in a timely manner. And the coroner's office are developing a sharing agreement to inform public health, the local public health, about individuals who have died so that they can follow up. In June, we had a big meeting. We had 80 attendees, and the discussion came around a marketing strategy and public awareness campaign. And, you know, I would like to see the marketing strategy really embrace trying to destigmatize illegal substance use, such that people will call for help. People will tell family members when if they are struggling. There's been new opioid treatment guidelines, and another concern that comes here, I think treatment guidelines are excellent, that physicians, when they start prescribing, it's good to have guidance as to how long, what sort of treatment, opioid treatment they should use. We have to be very careful that there isn't a push to get people to stop opioids without sufficient support, because we know that will push people into using illicit substances, and we've seen that, and there's evidence of that from the US. And also opioid agonist treatment. So Suboxone, previously you had to have a methadone license. Now it can be prescribed by any physician. So we're hoping that means that there will be agonist therapy more available throughout the province, because it's certainly limited in some of the more rural areas. We want to improve testing of the substances, and again, you know, as people know, there isn't a simple reagent test that says yes, no, you've got fentanyl here. You know, how do we expand the use of mass spectrometry beyond the policing and beyond the stuff performed by the coroners? The police are excellent in situations when we have many overdoses to test so that we know what's going on, but that's not their main priority. They are testing for the enforcement purposes. Supervised injection sites, we've got 2 in Vancouver. We would like to expand and have more. I do an annual survey with people at the harm reduction distribution sites, and certainly it was found to be very acceptable to many people who used the harm reduction sites that they would use a supervised consumption site, and increasing access to naloxone, which I've mentioned. So just a few maps that kind of give you an idea very broadly of the things that we've been looking at. I showed you this one earlier, which is the distribution of illicit drug deaths. This is one where we've plotted the administration of naloxone by ambulance crews. So again, very much this is where an opioid overdose is suspected. This is a map showing where we have our take-home naloxone distribution sites, and this is where the opioid agonist prescribers are. So by doing some of this mapping and overlaying the mapping and using Tableau, we're able to identify quite a few empty patches where there aren't opioid agonist prescribers, but we're certainly seeing deaths, but we have got our naloxone kit distribution in there. So using the evidence and the information we can to identify where else we can intervene. And it would be nice to say all this is helping and things are working, but as many of you are probably aware, and you saw what went, somebody shared information about this through NDEWS. You can see somebody has used our poster, the poster design, and this is from Fraser Health. There were 36 drug overdoses in actually 36 hours. These were the ones that attended Surrey Memorial Hospital, so these are the ones that made it to emergency departments. We're aware of others that potentially had naloxone used and did not go to the emergency department. The police were able to obtain some substance for testing, and we have been informed yesterday that 2 of the specimens, 2 of the samples they tested had furanyl fentanyl, which we hadn't previously seen in BC, and I don't believe we'd seen in Canada either. But this was in crack cocaine, so potentially people smoking crack who may have been opioid naive, but who were having overdoses. So, you know, we just have to, this is just showing what we're doing, how we're trying to address, but obviously not keeping one step ahead, but just having to respond. So I think in summary, what I've told you is we've got the highest number of overdoses in BC ever seen. Fentanyl prevalence is increasing, it's everywhere, it's in different populations. Some people taking fentanyl don't know they're taking it. Others, we admit, are seeking it out. Some people say they are seeking the effect of fentanyl. We need to be consistent and realistic with safer drug use messages, not just saying don't use, but giving people ideas of what they should look for. We've been mapping to try and identify where we need more take-home naloxone, where opioid agonist therapy is needed. You know, we also, take-home naloxone is effective, but it's not enough. It's more of a band-aid. We need to really look further upstream, and we have to be aware when we're introducing things to be careful of unintended consequences of any of our interventions or opioid reduction. So that's the end of my presentation and where we are in BC. So I am delighted to now hand over to Ms. Michelle Craig, who is the Acting Executive Director at Addictions and Mental Health with Alberta Health. Thank you.
Hello, everyone. It's very nice to be here today, and thank you very much to my colleagues for the fabulous overview and introduction and providing an excellent background. A lot of the demographic and clinical information that Jane referred to is very much what we're seeing here in Alberta as well. To give you a quick overview of what I'm going to go through today, we'll start with a little bit of information about Alberta. And you'll understand some of our issues are very similar to BC, and as soon as I show you the geography, if you don't already know, you will understand why. Then I'll provide some information about what we've seen here in Alberta as drug use trends, also rates of harm, particularly deaths and ER visits, and also treatment. And then we'll talk about the response that we have underway and what impact we've had on that thus far. So that's where we're heading. Sorry. So this is a map of Canada, obviously, and Alberta is in the red there. You'll see British Columbia off to the left, and the lovely little bumpy line down at the bottom is a line, that's the Rocky Mountains between British Columbia and Alberta. Sadly, we thought perhaps those Rocky Mountains would stop things like fentanyl coming across our borders, but it is most certainly has not prevented fentanyl from coming into the province. So by our very proximity, British Columbia and Alberta, this is part of the reason why we're seeing, we know there's transportation and lots of people moving between the two provinces, and so we're seeing very similar issues. We will note as that we move east across Canada. In Eastern Canada, what they're seeing a lot more of issue with is fentanyl patches as opposed to the illicit fentanyl pills. So it's quite interesting in that sense in terms of the geography and impact on it. In terms of Alberta and what we look like, we're a slightly smaller population than British Columbia with 4.25 million people, which is roughly 20% of Canada's population. Our two major cities are Edmonton and Calgary. Edmonton is roughly in the center of the province, and Calgary is about 400 miles, 300 miles further south, just by way of reference. Of course, we also have the oil sands in Fort McMurray up in the northeastern portion of the province. And of course, that area, because of the oil sands and the workforce there, has a very migratory population. So we tend to, and a very migratory population of primarily men, and in the age zone, sort of that 25 to 35, 45 age range. So we see a great deal of addiction, and we've seen quite a bit of fentanyl use up there. Of course, with the wildfire situation that we are in the process of recovering from, that caused evacuation of the entire city of Fort McMurray for a number of weeks, we also anticipate that we'll continue to see issues, if not maintaining, probably increase over the next 3 to 5 years as that community goes through a very significant recovery process from that wildfire. I think another thing I want to point out about Alberta is we have a publicly funded healthcare system, as we do across Canada. What's a little different in Alberta is that we have one primary public health service provider. So Alberta Health Services, which is our operational arm of the government, of which I work for the government piece, they provide all of the services in acute care, emergency services, public health, addiction, mental health, etc. So although we do have some for-profit and not-for-profit services in mental health and addiction, our primary service provider of public services is certainly Alberta Health Services. Because we have one umbrella agency, one administrative body essentially that provides services across the province, this has really allowed us to roll out things relatively quickly, relatively consistently and uniformly across the province. For example, British Columbia, Jane spoke about the difficulty of getting data. That has never been a problem in Alberta because we have this one large health authority, so we haven't had to go down that road. So that just gives you a bit of context as we move forward here. So by way of providing a little bit of an overview in terms of drugs and drug use within Canada, and Alberta in particular, you'll see the Canadian Tobacco, Alcohol and Drug Survey. This is 2013 data, past use. We are just about to relaunch this survey, so we'll have more recent data soon, but not quite yet. So what you can see here is that the drug use in Alberta is comparable to that of what you see across Canada. Obviously, alcohol is the #1 drug. I don't think that will surprise anybody. The use of illicit substances is relatively small. And also, I must note that this data was collected by phone, so it probably misses some subpopulations who don't have phone access. And of course, this is self-report. The next slide is, again, talking, sort of referring back to an issue, again, that Jane referred to in terms of prescriptions and the impact on opioid use. So this triplicate prescription program is a program that we have that enables us to track prescriptions across the province for specific drugs. Opioids are in one of the classes of drugs that we track using this process. What we can see here is that there has been an overall increasing trend of use of prescription of opioids in particular, with a gradual increase in prescriptions overall. You'll notice this big change in the 2012, and what happened there was a change in the data collection. So we moved from a manual entry to an electronic gathering through a system that's called our pharmacy information network. So that's what that difference there. So it's not a real statistical difference necessarily, but does reflect a difference in how the data is gathered. Of course, what this also indicates is that with this relatively high and relatively increasing rate of opioid prescription, a part of what we're doing here is also making it easier or more likely that more people will become addicted to opioids and may end up moving to illicit sources. Here we have 24 prescriptions, 2014 prescriptions for opioids in particular. You can see that oxycodone prescriptions are far outnumber the rest of the prescriptions. We do have fentanyl patches about a quarter of the way, third of the way down the page, but again, it's a relatively small number, which again speaks a little bit to the difference in the issue we're currently seeing between Western and Eastern Canada in regards to illicit fentanyl. This slide references emergency department admissions from all substances. Oops, sorry. There we go, I missed one here. By all substances in 2013 and 2014. This is standardized information, and really what you're seeing here is that the substance-related disorders and admission for them is increasing, and part of that is due to alcohol, but certainly part of it is due to other substances as well. When we break that down into admission by substance, the particularly bold blue line is opioids, and you can see that we've had a fairly rapid increase in that. Whereas cocaine, we've had a spike and then sort of settling down a little bit. We've seen a huge increase in cocaine and also others, in opioids and other stimulants. This slide shows the number of emergency department visits to poisoning, related to poisoning by opioids or other substances of abuse. And again, you can see that the big piece here is that accidental poisoning, if you can't read it, is the blue bar. Intended self-harm is the orange one, and green is adverse reactions. Gray is undefined. There's a tiny little green one there, and that's adverse reactions. It's actually hard to see because it's so small. This shows us that the largest number of overdoses relate to people accidentally ODing while using illicit opioids and largely fentanyl. I think the other piece that comes into play potentially here is, as Jane mentioned, is that people often don't know what they're taking, and that may play into this as well. This slide shows treatment cases. So what are people coming into treatment for? Alcohol continues to be the #1, which again, given the usage of alcohol and the rate of addiction to alcohol, this is not surprising. Then tobacco. But as you can see down the green line, second from the bottom, is opioids. And again, you're seeing a slight increase there. But on the whole, it's been fairly constant. This graph shows new treatment cases reported past year substance use by substance class, as you can see in the title. And again, in terms of opiates, it's been relatively stable over time. We've seen more increases in some of the other areas, but opiates has been reasonably stable with some increases. Looking at occurrence of selected drugs in sudden deaths, You can see really sharp increases in sudden deaths relating to fentanyl. Also, in looking at this information, you can see also the oxycodone is listed here and codeine. So obviously we have some opioid issues. We know the numbers here indicate the total number of cases where the drug was detected. So detected, but not necessarily the cause of death. We don't have that kind of definition. And Matthew spoke a little bit to how the medical examinations work and so why that's happening. So this is detected. We also know that many cases contain multiple drugs of abuse or prescription drugs. And in this case, in that particular line, it would be fentanyl was one of those. Morphine is not included here because it can come from multiple sources. So this is a slide showing deaths in Alberta and relative to the population. So the northern part of the province is got a relatively small population. The majority of the population of the province is centered in Calgary and Edmonton, as I noted, so that's further south. However, when you look at the rates of deaths, it's much, much higher in the north, which is 11.6 per standardized population as compared to the other areas. So in 2015, there were a total of 272 fentanyl-related deaths in Alberta. In Alberta, although we have one health authority that provides all of the publicly funded health services, they are actually structured into 5 zones. And we know that in the Calgary zone, there were 90 deaths. In the Edmonton zone, 75. The North zone, 57, although it was a much higher rate per population. Central was 35, and then the South was 15. So then in terms of what we've been doing to address this issue, one of the, of course, we're one of the NDEWS sites as well, and so we were aware of the alerts. We've also had about a year ago or so, we had a change in government, which also changed some of our orientation and direction on some of these issues. But when these deaths really started to get attention, both in terms of the numbers of deaths and certainly in the media and concern from community, really caught the attention of government and everybody else that had been in the field as well. One of the things that happened in December of 2015 was the new government established a fentanyl response team, which is comprised of cross-ministry representatives as well as cross-sector and community partners, including people from corrections, our Indigenous communities, social services, education, advanced education, and many other partners. And of course, Alberta Health Services, who is our primary service provider, was also at the table. This group met monthly, and this meeting was chaired by our Deputy Minister, which is an indication of the importance of this issue. He reports directly to our Minister, who reports to the Premier. We initially were doing weekly, daily updates actually, and then they turned to weekly updates on our progress on this issue. So this became a very significant and very important issue to our government, and certainly investment of both time and resources was put into addressing this issue. These are the 6 things that we started to work on immediately. So take home naloxone program, an emerging substances monitoring system, which we're in the process of developing, a focus on prevention and education, Aboriginal and rural treatment services, because in some of those rural and remote areas, particularly in the north, it's very difficult to access services, so we needed to come up with new ways of reaching those folks, and also ensuring that our Aboriginal population had access to the services and knew what to do with them. We were seeing a particular impact on reserve in terms of fentanyl deaths. And in fact, the Blood Tribe was one of our canaries, if you will, in that they experienced a number of deaths related to fentanyl in a very, very short period of time. Also, of course, increasing treatment access and looking at harm reduction. Unlike British Columbia, which has worked in harm reduction and had a number of harm reduction strategies in place for a number of years, Alberta is of a slightly different political stripe, and historically we have just had less harm reduction. But it became obvious that we needed to do something and do something fairly quickly, so this has become more of a focus for us. My apologies. So in our immediate response, this took a little while to pull together, but what we now have is we have 9,000 publicly funded take-home naloxone kits being distributed from almost over, I think it's actually now over 800 sites across the province of Alberta. Those sites include community pharmacies, community agencies who provide addiction treatment services, for example, all of our emergency departments across the province, our corrections or prisons, ODT clinics also provide the kits to clients, and we have a program called PCHAD, which is a involuntary detainment for a very short period for youth that are at danger or have been involved in drugs, and so with legal support, they can parents can have their children put into a program for a very short period to try and help them address the drug issues. And that program is also providing naloxone kits to children coming into that service with the take-home naloxone kits. So this was an incredible growth. In December, we had approximately 8 agencies providing kits in 9 locations. By February, I guess by April now, we have well over 800. So we have seen a tremendous growth. So we had so much further to go than BC. We had so much further because we were starting so much further back, but I think we've done a pretty good job of catching up, at least on this particular aspect. I also had to acknowledge and thank British Columbia, and in particular Jane and her colleagues in her agency, because we have learned so much from them and borrowed so much, including the campaign that she mentioned of the education program. So we very much appreciate that work, and we're very grateful to have it readily available for us to use across the province of Alberta as well. Every time a kit is dispensed, there is a training that is provided to the recipient. We are trying to track people's use of the kits, but we're finding our results are a little bit shaky on that. We know that approximately 300 kits have been used, but we're also very aware that that's an underreport. We're hoping to improve that and our data ability with that over time. One of the other things that happened was ministerial orders, as Jane also alluded to, happen in BC, to allow EMTs, those are emergency medical technologists and emergency medical responders, to administer naloxone on ambulances, and nurses and registered psychiatric nurses to prescribe. Again, this change of scope that happened in legislation that we were able to do through a ministerial order allowed us to have a lot more people providing naloxone quite quickly. And as Jane also alluded to, the reclassification of naloxone to make it available without a prescription in pharmacies has really made a huge difference in Alberta in particular, where we're able to start distributing through community pharmacies. Oops, my apologies. Sorry. Here we are. My apologies for the confusion with the slides. So this is the number of naloxone kits dispensed by zone. As I mentioned, Alberta Health Services has 5 zones across the province. And you can see this is between January 24th and May 22nd, week by week. Obviously, it has increased over time. The zone distribution isn't particularly relevant, but certainly you can see that the greatest number of kits were dispensed in early May, when we were able to have naloxone distributed through pharmacies without prescription. On average, it's about 19 kits a week that are being dispensed. The Edmonton area has the largest volume of kits being dispensed, with about 9 kits per week. Calgary has the next highest with about 5, and again, it makes sense as those 2 being the most populated areas of the province. And then again, the rest was scattered across the province. And the vast majority, again, of those were through the pharmacies. So some of the other actions of those 6 that I mentioned earlier, the second one is an emerging substances monitoring process. So this is a piece of work that is in process. But what our goal is to develop both an internal and external-facing, cross-sector information services, be it a web or a dashboard or something of that nature, where we track information right from what we're hearing on the streets through our police and enforcement partners, to what we're seeing in emergency departments, to what we're seeing in acute care in terms of admissions, all the way to the medical examiner data. What we're really hoping to be able to do is pull all of those sources of data together, display them both for an internal purpose to facilitate our planning, but also externally so that people are aware of what's happening across the province, and not just for opioid use, but for anything that's emerging. One of the things that we're seeing right now is we're hearing a lot more reports, again, as Jane alluded to, of the fentanyl analogs are starting to come up. Because we haven't been looking for them, they're harder to detect because we aren't testing them. It's taking us longer to get a grip on that, but we know that's happening. We also now have reports of, we know people are actually asking for things like W18, for example. So there's a lot of action happening on the street, if you will, in terms of not just fentanyl and the pieces of fentanyl that we're aware of and know about, but certainly in terms of the other analogs and other opioid versions that seem to be coming out. The prevention and education goal, Alberta Health Services has done 2 province-wide public education campaigns, and they would have been targeting, they did target those, the age groups most at risk, and did a lot of interesting and innovative campaigns, for example, in bars and that type of thing. The other thing that we've done here is develop an information sheet for parents and teachers of children and youth, recognizing that this isn't the primary population that is being harmed. We were under intense pressure from so many people wanting information to be shared in schools. So we've created this information sheet, provided some information, and said really what you need to do with children and youth is spend time with them, talk about this over a period of more than just one information sheet, but many, many days and many instances, and follow best practice. So although we're providing this short sort of snapshot of information, we're also recommending a longer course of action for people. We love the information from BC. However, we were also very aware as we went to send this out to our school colleagues, thinking we are not sure parents of kids in grade 8, for example, would appreciate something that suggests that their children know their source. So with that pause in mind, we backed up and developed this information sheet. Another piece of work that has been underway is Aboriginal and rural treatment, working with both our federal government as well as our provincial colleagues and our individual Aboriginal Indigenous nations. We've done some tailored education for those groups. We've done a lot of information sharing and in-person information sharing at conferences, etc. We've worked really, really hard with our federal counterparts to ensure that there's reserve to naloxone kits on reserve, and a lot of troubleshooting. Quite often, those areas don't have the capacity or resources to be able to address some of these extremely complex issues that they're facing. So we've really been working hard to work with them and in partnership with them to identify and address any issues that they're experiencing. Items 5 and 6, increasing treatment access. The government has provided grants to Alberta Health Services to increase access to opioid dependence treatment, recognizing that that's one of the things that really needs to happen across the province. And we've also provided grants to increase access to publicly funded addiction treatment beds. We're also, as I mentioned, working on harm reduction policy and looking at the opportunities we have to develop harm reduction strategies across the province. And again, as I mentioned earlier, we have a huge opportunity here because we haven't done much in the past. And we also have the very valuable opportunity of learning for our much more advanced colleagues in British Columbia. Another piece of work that this is related to is a recent review of the addiction and mental health system that was done by our government. And with a report that was released, we are now implementing what's called the Valuing Mental Health, Alberta's Addiction and Mental Health Strategy. And this has an addiction focus as well as a mental health focus. And all of this work that I've just mentioned will continue under this strategy. So this work will continue moving forward. Although certainly at this point, we're hearing less about opioids and fentanyl in the news. However, certainly in listening in on a recent meeting of our colleagues in the enforcement world from corrections, border services, this issue is not going away, and in fact, it is probably growing and becoming more difficult to manage. So definitely something that we need to continue our focus and efforts, and continuing to put our resources into trying to help Albertans avoid the fate of fentanyl in terms of deaths, and to keep people as healthy as we possibly can. That is the end of my presentation. So at this point, I will hand it back to NDEWS. Thank you.
All right. Thank you very much, Dr. Young and Dr. Buxton and Ms. Craig. We really appreciate your presentations, and you really gave us a whole lot of very useful information to think about and digest. And I am going to go back to share screen, but in the meantime, please remember that you're welcome to submit any questions that you have in the Q&A box, and we will go through them in a couple of minutes. Oh, what did I do? I just went through things too quickly. All right, so anyway, just to remind you of a couple of things, there were a number of websites that our presenters mentioned during their presentations. And so if you're interested in taking a closer look at the bulletins and alerts that Dr. Young had mentioned, you can find them on www.ccsa.ca. And the resources and data and other information that Dr. Buxton mentioned, you can find at knowyoursource.ca. That's where the posters are, and towardtheheart.com. And if you're interested in finding additional information, training materials, and a webinar on naloxone, you can find that at www.bc, that's British pharmacists.org/naloxone. So I hope you will find those sites useful. And of course, always remember to visit NDEWS at www.ndews.org. So I'm going to start running through the questions that we have had come in. And so the first question we have is from somebody who was interested in if you all have any information regarding clandestine labs like methamphetamine labs converting over to making fentanyl or mixing fentanyl products in Western Canada. So if you want to speak up and answer, please remember to unmute yourself.
Hi, it's Jane. I would just kind of share that my understanding is that the vast bulk of the fentanyl that we are seeing in BC is actually imported rather than it being produced here. We this is the information that I have from the enforcement folks. So yes, there is fentanyl being produced here. I'm not aware of converting methamphetamine labs specifically.
Okay, thank you. We did have one instance here in the States, in the southwestern states, in the Phoenix area, where there was a lab that had been processing synthetic cannabinoids that actually mixed the synthetic cannabinoids with fentanyl. And so that creates its own issues, of course. The next question we have is from somebody who wanted to know if there are any good Samaritan laws in Canada to address the reluctance of people to call 911 in places where police are more likely to show up.
Can I answer that one too? Sorry to leap in. But yes, there is a law, the Samaritan law is being put through Parliament at the moment. It's had its second reading. But of course, this is in reference to possession. And in the research that we did in the focus groups, the possession isn't the main concern. It's having outstanding warrants and it's having a breach of probation. And those are the main reasons of being concerned at getting the police involved. So a Good Samaritan law does not cover that. The Good Samaritan law tends to be for possession. So we're working with the police. Basically, my understanding, and I may have this wrong, is that the police feel when they attend and there is a scene that they need to get the names of everybody who's present at the scene. And if they have a name, they then run it through the computers to see if there's outstanding warrants or if there are breach of probation. And that's one of the reasons that people will run off, why they're more likely to call if it's on a street, because they can go. And I'm not sure how much the Good Samaritan law will affect that. But I think it's great to get the talking going, to get, especially for youth, to understand that they're not going to be arrested just for using drugs or for somebody overdosing where they're close by.
Okay, thank you. Our next question is from somebody who wonders if you have seen any cases where other drugs such as cocaine have been cut with fentanyl.
I can respond to that.
Crack, but
I can respond to that. Certainly, the cocaine is a really good example of that. We have certainly seen that. I think Jane's slides very much pointed that out in terms of people don't even know what they're taking necessarily, and we're certainly seeing that as well. I'd also like to refer back to the first question as well. In Alberta, we have found, our enforcement colleagues have found a few labs, and quite often what they're saying is that the meth and fentanyl labs are coexisting. Whether they've actually changed from one to the other, I'm not sure, but because I understand from what my enforcement colleagues are saying that the processes are somewhat similar. But again, as Jane has said, it's mostly imported. In our case, the way we view it, it's coming from BC, but only because it's coming from China through BC to Alberta. I think you're on mute.
all right, our next question is from somebody who would like to know if you have any data on how many naloxone doses are given to a patient by an EMT on average during an overdose, and if that number differs depending on if it was a heroin overdose or a fentanyl overdose. Anybody have any information on that? Okay, we'll look into that and get back to you.
Sorry, I was trying to unmute and clicking on the wrong.
Okay.
Certainly, we've seen an increased need of doses, and that's why we've increased our take-home naloxone kits to have 3 instead of 2. And we're hearing this weekend, for example, when fentanyl was detected in these overdoses, that people are needing quite a few grams of naloxone when they arrived at the hospital. So yes, we are seeing that fentanyl is needing more naloxone than the standard 0.4 that we often give.
Okay, thank you. Our next question is from a viewer who would like to know if it is possible for individuals to abuse or misuse the naloxone in the kits that are given out.
Jane and I, we're all shaking our heads no.
No.
Yeah, okay.
We had people concerned that there may be a threat of reversing somebody's overdose. Reversing somebody's high, but we have not seen that happen. It has no effect if there's no opioid on board.
The most negative effect that we've seen in Alberta is publicly funded kits ending up on Kijiji for sale.
Okay. Thank you. Our next question comes from a viewer who wants to know where they could go to find data on opioid overdoses among children and people under 18 years of age.
We go to the Drug and Poison Information Center, we collect that information and we discuss with them. We look at the numbers. That's one of our data sources we look at on a regular weekly basis.
And in Alberta, Alberta Health Services has some of that information, as does the government of Alberta, which is where our sources are drawn. But it's relatively small numbers, comparatively speaking.
Okay. Thank you. Our next question is from a colleague who wants to know if you could please explain further the internal and external cross-sector dashboard for emerging substances, and he would like to know who is conducting these tests.
At this point, it's a concept, so there's no test to conduct just yet. very conceptual and developmental at this stage. So really what we're trying to do is pull a number of existing data sources together. So there is an agency called Alert in Alberta that works with all of the police agencies across the province, for example, and they have a number of pieces of data that they track. Then, of course, we have Alberta Health Services, which is a lovely repository of all of our health service data, from ambulances to emergency departments to hospitals, etc. And then we have our medical examiner data. So looking at all of those sources and also the prescription information that I spoke about earlier, what we're trying to do is find out what everybody has and then figure out how we can build something together that actually showcases all of that data and provides all of us with information. One piece that we don't have, which would be lovely to have, is some of what I suspect Jane and her agency have, which is more of the user data in terms of bad trips or drug testing or that type of thing. So that's something in the long future we would like to build out. But at this point, this is truly a concept and not yet a reality. I wish we had something to test. We're just not quite there yet.
Okay, thank you for that update and information. We have another question from a viewer who would like to know where you think your fentanyl is coming from. I think one of you might have mentioned China earlier. Is there any place else?
The vast majority, we understand, is coming from China through BC to Alberta.
Okay, thank you. Our next viewer wants to know how much the governments of each of your provinces are paying for the naloxone that's being distributed. Are they chipping in for any of these kits that are going out? And what dosages, what are the dosages that are chosen?
In terms of what's being paid for publicly within Alberta, we have those 9,000 kits, which were all funded by government. And we're currently still using 2 vials, although we're recognizing and hearing reports that more are often needed on the street. So we're actually looking and reviewing that right now. So the kits are, because we're doing a very bulk buy, the entire kit is roughly $20, $25. And then we're then distributing them out to all of the distributing sites. So that's the price of it. Government has paid for 9,000 of those kits. We have approximately 5,000 left that have not yet actually been dispensed to Albertans. So we will use those. In the meantime, of course, we're also starting to look at nasal naloxone and trying to sort out who should get it, how should we distribute it, what should we do with our existing kits, etc. So we'll work through that process, but we have a number of questions to answer. I'll turn it over to Jane for BC's view.
So from the BC perspective, up until now, we've been putting the kits together ourselves at the BC Centre for Disease Control, and using the 3 vials, the actual naloxone itself costs less than $5. So our kits are as cheap as they can be. We are distributing 2 sites, an average somewhere between 500 and 1,000 kits per week. So it is, as we expand, we're looking at other ways of making sure that distribution goes to those that need it. And the intranasal naloxone, we would not be considering for our kits at this point, but potentially for enforcement folks, for correctional officers, for people who are not able to carry the needles, because the actual price goes up a lot, and if we're distributing 1,000 a week, it's rather unattainable.
Okay, thank you. Our next question comes from a colleague who's joining us from the United Nations, the UNODC in Vienna, and is interested in getting more information about W18 and W15. For instance, this person would like to know if you consider these substances to be opioids, and what is the cause of the dependence if they have low affinity over multiple mu opioid receptors.
I could try and take a stab at that one. So we've kind of been thinking about this a lot, like why did W18 appear on the market? And it's kind of, I think a certain amount of this is going to be speculation, but we kind of think that it probably was people looking for another kind of active ingredient to be included in drugs sold as opioids. And because of its, and they probably looked to old patents, failed pharmaceutical. W18 in that series was originally published. The patent was published, but it was a pharmaceutical product that was never brought to market. According to very early testing that was done on it, it appeared to be a very, very highly potent analgesic, and probably for that reason, whoever was doing this, organized crime, saw it as being a potential substitute for fentanyl to be as a new active ingredient. And at the time, W18 was also not controlled in Canada. So I don't know if really, now as the research has evolved, are they opioids? I think it was just an adulterant that appeared in the market as an active ingredient in these pills, and probably will disappear quite quickly because it might not have a high affinity for opioids, for the opioid receptor. I'm not sure asking whether or not individuals are seeking it out because they have an actual dependence on W18. So I think that it's probably in that context. Maybe my colleagues have more information to share on that.
In terms of people asking for it, what I think has happened in Alberta was that there was a pretty good media splash around the W18 and it being that much more powerful than fentanyl. And Matthew spoke to that in his presentation in terms of how that's perceived. My sense is that it may be being asked for on the street because of the media-related splash. I've certainly anecdotally, heard my family and friends talking about W18 and why they would be doing that other than exposure to the media. I have no idea, unless they have a life that I'm not aware of, which is possible. But I really do think it's related to the media.
Okay, thank you. Our next question is from a viewer who would like to know if minors, that is individuals under the age of 18, can obtain a naloxone kit.
Yes, in BC we have a mature minor policy, which is for all harm reduction supplies and distributions. So that it cannot, if somebody is thought to be able to respond appropriately and understand what they're doing, yes, there is no problem giving people with kits.
It's certainly the same case in Alberta. And I mentioned the program that actually serves some youth who are having some addiction issues. And they are absolutely prescribing those kits to youth who have been using opioids. So yeah, not a big issue.
Okay, thank you.
Just to supplement that, we've actually done some focus groups and worked with youth around giving naloxone kits, and we did find that they have requested to have more training because many of them do not inject drugs. They are not comfortable with needles, so we've adapted. We're making a new video, we've got some new artwork that they've developed, and we need to have more hands-on training for youth when we do distribute the naloxone.
All right, thank you. Our next question comes from a viewer who wanted to get your recommendation about what age group you should start education programs with about the use and effects of fentanyls and other opioids.
I'll take a stab and then I'll pass it over to Jane and Matthew. Again, I think predilection to addiction, like any addiction, really has its roots in early childhood. So, and I know that seems like going a long way back, but it's not about education. It's about having strong, stable, loving homes where children grow up feeling supported and safe, that they're able to develop resilience, to be able to say no when they're handed challenges, and also be able to take safe risks. So I recognize that's going way further back. I think in terms of the conversations, again, you need to start as young as possible, but it's conversations about risk-taking and healthy risk-taking and healthy behaviors and healthy lifestyles. And those conversations need to happen repeatedly and over time in a way that invites and involves both the children and as they grow into youth. And I pass it over to Jane for more on that.
Yes, I would agree. I think that's a good summary. Thanks, Michelle. And I think the conversation needs to start early, make sure that people, children are willing and able to discuss the topic, that there is an open forum for them, and also to make sure that the discussion, the information is tailored for the appropriate age. A lot of the just don't use messaging may be great for the younger kids, but I think we need to be realistic when we're talking to older children who see friends using marijuana who aren't growing horns or having problems.
Okay, thank you for that. So we've had a few viewers who had questions about fentanyl analogs. And so there was one viewer who wanted to know if there were some analogs that you consider to be more deadly than others in Canada. And there was another who wanted to know in particular if you had seen any instances of acetylfentanyl or carfentanyl in your areas.
I can start with the easy part, not the chemistry part. In terms of Alberta, we have seen a seizure of carfentanyl recently, and we've certainly seen acetylfentanyl and some of the other analogs as well popping up.
Ditto for British Columbia. When we're talking about which is the more deadly, I think Matthew gave a good description. Is it's not so much which is necessarily the more potent, but how much is actually in the drugs that people are taking and how well is it mixed. Obviously, carfentanyl is a bit of an exception because that is can be very deadly.
All right, thank you. Is there a particular place, like maybe on one of the websites you've mentioned during your presentations, where people might be able to go to find more information about the fentanyl analogs or the other opioid type substances like W18 that we talked about earlier?
This is Matthew. We're the CENDU. If we go to www.ccendu.ca, that will take you to our CENDU webpage, and there's alerts and bulletins. And in about a month ago, we released a bulletin on novel synthetic opioids as included in counterfeit pharmaceuticals and other street drugs, and it kind of goes through a lot of the drugs that at the time we had seen as these active ingredients in pills and powders for sale, and kind of talks a little bit about what we knew about them at the time and how and with their presence in Canada, or what we knew at the time of their presence in Canada. So, but going back, like in some ways, one of the things that struck me in pulling together that bulletin and speaking with partners and also hearing the presentations again today, is that in a way it doesn't change so much the interventions. I mean, it will change if we know that some of them, that naloxone doesn't work on some of them, that might be something that changes the intervention quite substantially. But in the end, what we're really talking about is great variability of a drug that causes somebody to stop breathing, and how do we work with that? And when you have a lot of these fentanyl analogs and other kind of novel synthetic opioids appearing in these counterfeit pharmaceutical drugs or street other powders, it's really about that variability and how difficult it is for clandestine labs to get the mixture right. So I think of just underscoring that point is pretty clear. I think what we're seeing is, at least in Canada, is ways of kind of skirting existing legislation and pulling it, and also then driven by economics and what can be purchased cheaply and what can be brought in over the mail to be then tableted or put into powders and then sold in the illicit marketplace. And so yeah.
Okay, we just have a few more questions, so I hope everyone will bear with us for a little bit longer as we get through these, and then we'll wrap things up with our brief poll that we usually do at the end of our webinars. So we have a question here from a colleague in Cincinnati, who first off thanks you all for doing a very nice job putting all of your information together. And she wonders how soon after discovery of an outbreak related to fentanyl, for example, are alerts getting out to the masses to help prevent additional overdoses?
I think the media are really our friends here, and certainly the information gets out as soon as we know. Obviously, it's tentative. We don't know exactly what the substance is, but they do, and the media often pick up because we inform the media when we're concerned. As far as the posters that I showed you, the ones which say alert and beware, those also are getting out within the same day.
And in nationally, we work with partners like Jane and Michelle, and to try and pull that information together in a reasonable way that can then inform other partners from across Canada. And for that, we really kind of do not only a risk assessment, but also just, do we have anything of value to add to the conversation? And if we don't really have anything extra to inform people about, then we kind of, it's kind of a bit of a bigger threshold that we use before putting out a new alert.
Okay, thank you. We also have a question from a colleague down in South Florida who was looking, Dr. Buxton, at one of your fentanyl toe tag posters, and he noticed that it featured an African-American deceased person, and he wonders if that is representative of opiate users and decedents in Canada. And we also had a question from another viewer who wanted also to know more about the demographic characteristics of individuals who are prone to abusing opioids and overdosing.
Certainly, African Americans are not high on our list. We don't, our population, and now you mentioned it, I hadn't realized, and I'm not sure that that is the case on the poster. I will now go back and have a quick look, but I don't believe that's what it's showing. Demographic-wise, we do see a higher preponderance of people who are Indigenous, who use substances over and above what we would expect on a population base. But really, it's all folks, rather than it being a specific population. I don't know about Alberta, Michelle.
In Alberta, we're certainly seeing, in terms of as a percentage of the population, our Indigenous populations are being affected more heavily. However, that really speaks to their socio-demographics and the social determinants of health and the lives that they're trying to live, and that they represent more heavily in many areas of health and mental health and child welfare and everything else. So it really speaks to the conditions that they're trying to work through and live in. So it's certainly not specific to race in that sense, but much more a factor of social determinants of health, poverty, poor education and opportunities, etc. Well, I think what we're seeing that's a little bit unique with fentanyl as compared to some other illicit substances is we're hearing and seeing more of the harms happening in middle and upper class residential neighborhoods where we wouldn't normally expect to. One of the reasons we expanded our program beyond our harm reduction agencies is because they do a fabulous job of connecting and providing support and resources to vulnerable populations, but they didn't have the same reach into some of the areas that were actually experiencing more harms, which were some of the bedroom communities around our larger cities. So that's a little bit different with fentanyl, and I think it speaks to fentanyl seems to be hitting everybody much more than some of the other drugs or what we would have expected, which are often seen more often in more vulnerable populations.
Okay, That was very helpful. Thank you. And so people are still sending in questions, so I'm going to just apologize in advance if we don't get to everybody. I want to just take a couple more questions so we can wrap things up today. So the next question comes from a viewer who wanted to know if patients who have been resuscitated from an overdose are referred to drug treatment programs, and what is the turnout rate for that?
In Alberta, they're offered naloxone kits. They are also given the option of treatment, but treatment is, of course, voluntary. So that is a decision they make as individuals. We don't have data pertaining to particularly this where somebody who's experienced an overdose going into treatment. We don't have that data readily available at this point.
And it's very similar in BC. Certainly there are teams that wraparound teams and sort of active trying to look at alternatives and talking about substitution or agonist therapy. And this is part of what we're doing by having it as a reportable disease, is trying to track people and find out what happens and how much people accept when they are offered and what is available.
Okay, and so as one last question, we have a viewer who wanted to know if you have any training conferences in Canada on drug abuse related topics.
The one conference that comes to mind would be the Issues of Substance offered by CCSA. Matthew, I don't know if you want to expand on that.
Yeah, I mean, I think when I was thinking about a training conference, this is a conference that's a bit like in the United States, the College for Problems of Drug Dependence, although it's probably a bit less focused on some of the research and a little bit more focused on the practice, although there is a good distribution of research and frontline practice in there. That would probably be the closest. You could find information about that on our website, www.ccsa.ca, and the conference is called Issues of Substance.
All right, thank you. And again, thank you, Dr. Young, Dr. Buxton, and Ms. Craig for participating in our webinar today. We really appreciate all of the information you shared, and we appreciate all of the questions and active participation that we got from all of the viewers as well. And we hope to be able to connect with all of you again when we do our next webinar. We are currently planning a webinar that will feature results from our own NDEWS research. We're coming to the end of the second year of our project, and we are excited to be able to share with you some of the findings and information that have been reported to us by our Sentinel community epidemiologists as a part of their annual site profiles. And so when we get something scheduled, we will send out an invitation over the NDEWS network and also post information on our website, ndews.org. And so I hope you will keep an eye out and will be able to join us for that. So I'm going to do the poll now, and I'm going to launch the poll. There's just a couple questions, and I would appreciate it if those of you who hung in for the long haul will take one more minute and just answer these questions for us. Thank you. All right. Well, thank you again, everyone. We really appreciated spending the time with you today, and I hope you enjoy the rest of your day or what's left of it, and we will see you next time. Thank you.